Hi, my name is Jailyn Avila. In this week's video, I'm going to be discussing the thoracic abdominal aorta in relation to aneurysms and dissections. Now, these are very important diseases that when you diagnose them quickly and at the bedside, you can dramatically alter the patient course in front of you and their survival and morbidity, everything about them if you can diagnose it quickly. In this video, we'll talk a little bit about some background. We'll show you exactly how to scan it, things to look for, and I think you'll enjoy it. Check it out. Moving on, we're going to talk about these things. I know that we don't always think about these like valves as part of the thoracic aorta, but I think it's important because all of these are like life-threatening things that involve the same structure essentially. Little anatomy, there are these great vessels. There's a brachiocephalic, there's the carotid and the subclavian on the left, and that's basically how things are divided. It's ascending up until you get to the vessels, it's the arch, and then at the end of the vessels all the way down, that's a descending aorta. And it's important to know because that can help kind of guide what is going to happen to your patient, like what their likelihood of poor or less poor outcome is, and what kind of surgery they get, and even if they need surgery. Now, in the abdominal aorta, what is abnormal as far as size? Like, when do we worry about it? Well, 6, we definitely worry about it. And it is abdominal aorta, not thoracic. 5 is like impending rupture, right? Greater than 3 is considered abnormal. Lower than 3, if it's 2.8, you might call it ectasia. The actual definition is 1.5 times normal. And that's actually a definition for any blood vessel when it's considered an aneurysmal. The problem with the thoracic aorta is that it is actually quite variable with the location at which you're looking at, and what it is the size actually is what matters as far as the, if you have someone who's, the mountain from Game of Thrones, or you have like somebody much smaller, they're going to have different thresholds, right? As a whole, the way that I think about this is this is the overall definition. And these numbers are essentially average, right? The closer that you get from the heart itself, the bigger it is normally. So 4.5, then 4, and then 3 down below the diaphragm, essentially. That's how it works. Now, the right way to do it, if you really want to be sure, and this isn't necessarily for us, this is more for our surgeons who are planning intervention, this is kind of the formula that they recommend. It's actually based off of the patient's body surface area. At one point, they consider it abnormal. I don't necessarily expect you to remember this number, the 2.75 centimeters over meter squared, but just know that there is a formula, there is a number that you can use if you're not 100% sure what the abnormal aorta size would be in your specific patient. This is our probe for the entire thoracic aorta, including the valve. Now these views, are we good? We know what we've seen these views. Please tell me you know what these views are. Yeah. What's the one on the left? Parasternal long, yes. We have the left atrium, mitral valve, left ventricle, the aorta, this is the LVOT, and that thing that we're seeing right there kind of coming together. Those are pretty thin aortic valves, normal. This is the RVOT. And then over here, we have a basilar parasternal short view. So we're a little higher than we normally evaluate, we normally teach. And that's why we can see the pulmonic valve, really good pulmonic valve right here. And this is the tricuspid valve. And we're seeing a little bit of the aortic valve, just a little bit of it right here. This is the mitral valve off-centered, right? Because I can only see one leaflet. But the reason that we are showing you this view specifically is to show you how much of the aorta we can actually see on just parasternal views, right? We can see the ascending, we can see the descending on multiple views. Here's a cross-sectional view of the descending aorta, which is actually a very good landmark to tell if fluid that you might see over here, if it's pleural fluid or pericardial fluid. It's a good landmark, but also we can identify dissections. And then if we can see it in short axis, we can probably see it in long axis as well. So you can just rotate off of the circular cross-sectional aorta and get that long axis view. So already we have ascending and we have descending, and we can also evaluate the arch. This exam is a little bit more difficult to get. It's not as easy, but what you do is you place again, the cardiac transducer. I usually just use the cardiac setting. I angle it just a little bit, a little tilted. It's not straight down, it's a little tilted because the aortic arch comes off and then goes back this way, right? So you want to try and line it up in the long axis of the arch itself, and you can see the arch. I mean, to me, it's pretty like easy. It's pretty visible. There's a couple of tricks. You can actually put a towel behind the patient's shoulders, have them sit up, put a towel, and that'll extend this way. And I've also found that holding a deep breath out actually, for whatever reason, brings the aortic arch a little closer to the suprasternal notch. So if you're having issues seeing this, those are two things that you can do. And you can see here, this is all the anatomy things, right? That's our first slide. We're seeing all of them here. So this is how we can look at the arch. I'm going to take a brief pause here to remind you about the Core Ultrasound courses. Check out courses.coreultrasound.com for all of your educational needs, and if you're looking for a long-term ultrasound curriculum, one that follows you over a year, and we have one-on-one hangouts, image review, the whole package, check out ultrasoundleadershipacademy.com. Now, back to the video. Now let's talk about a thoracic aortic aneurysm and how to measure it. How do we measure AAAs, abdominal aortic aneurysm? Where do we put the calipers? Outside to outside. We do something a little bit different with the thoracic aorta. We actually measure, it's say leading edge to leading edge. So we want to measure the outer to the inner. That's actually what we want to measure on ultrasound. So the places that we put the calipers are a little bit different. We want to naturally focus in on the root itself. And the root even has different things that it has. There's these sinuses of Valsalva. This is like a little kind of outpouching right at on the other side of the aortic valves. We have the sinotubular junction, which is basically where this slopes down into where it goes into a more tubular ascending aorta. That's why it's called the sinotubular junction. And all of those, if you really do what I do and nerd out in cardiology literature for 3 days this past week, there's a lot of different numbers for each of those things. But when you actually boil it down as far as what we need to know, the ER kind of people, we just measure the widest. And that's what we use our 4 or 4.5 centimeter cutoff. And often it's going to be the sinus of Valsalva, right on the other side of the valve. But just measure the widest portion of it and take your measurement there. Here is one that is an aneurysm, right? 4.7. And I'm measuring this past the sinuses right here. So you see the sinuses here. We have a little dip right there, but then it's wider past that. So that's why I measured there. And you want to measure as much as possible perpendicular to the axis. So you want to have a nice little cross. And this one right here, we would call this ectasia. So ectasia is the word where it's a little bit big, but it's not quite at that level where we consider it an aneurysm. Are we good with how to measure and where to measure? Leading edge to leading edge, outer of the superior wall, inner of the deep wall. Sometimes we don't need to measure, we can just look at this, right? This right here, right, is the left atrium. We have the aorta right there, and we have on this one, we have the left atrium down here, and this from here to here is the aneurysm. It's huge, right? And one of the things that I do is I like to not have to measure things if I don't want to. One of the things that I talk about is common bile duct. You know Arthur the aardvark? Not old school Arthur the aardvark, but the more palatable Arthur the aardvark that doesn't have the long nose. Well, before, there was a big proboscis, and, I don't think kids like that. That's what it's called.
This is a deep reference.
It's called a proboscis. If it knows.
Such a deep reference.
But you know what I'm talking about, right? It's the head and then the two little ears. That's what the common bile duct, when you look in the portal triad, it's the portal vein, the hepatic artery, and the common bile duct. If those ears are the same size, I don't actually measure. I know it's normal. If one ear is bigger, it's as big as the portal vein, then I measure, right? So the diameter of a left atrium, the average diameter of the left atrium is 4 centimeters. I don't really measure it or get concerned about it unless I think that the aorta is bigger than the diameter of the atrium. That's when I measure. And I say that because it's It's about being efficient, right? Another little like trick, the average width of the vertebral body in the lumbar area is about 4 to 5 centimeters. So I don't measure aortas unless they're over half of the width of the vertebral bodies, because I'm lazy and I don't like doing extra work. And this is one of those ways that you can be a little bit more efficient. You can also see this on a apical 5-chamber view. The 5th chamber would be the LVOT and the aorta. But it's a lot easier, honestly, to diagnose it on the parasternal views. This right here is a normal aorta. Typically, it's kind of smallish on that side, and it might be difficult to actually see it take off when they don't have an aneurysm. Whereas if we look over here, this is the aortic valve. This is the mitral valve. We have a little calcification there on that mitral valve. And we see this width of the aorta right here is at least the same size, if not bigger, than this left atrium over here. So we can see this on other views as well. Any questions or thoughts on the aneurysms? All right on. Let's move on to the deadlier one. Why do we do this? Like, why not just send them to CT scan? We might not have time. It's faster, and there's data to show that, which I want to be very clear. I obviously am very invested in ultrasound. It's like the thing that I know the most in medicine. And when you guys have worked with me, there's some shifts. I don't ultrasound that many people, right? Because I use it when it's beneficial in that patient. Sometimes academically, I'm just curious or I want to try something out. But we use it when it's useful, and this is why this specifically is very useful. Hey, Malak.
So going back to your little trick about the atrium.
I mean, I think it's kind of like an important trick, not a little trick, but it's...
Yeah, a huge trick. Massive trick. That's a doozy. Would the aorta coincide with or kind of correlate with, say, someone with a dilated cardiomyopathy? A lot of these.
No, it wouldn't. It would be normal. Like they have to be normal. They have to not have a history of mitral regurg or diastolic dysfunction. So yeah, there's always caveats to everything. Truly, thank you for bringing that up. Like, no shade. You're totally right. There's always caveats to these kind of things. It's assuming that you have a normal left atrial size. Absolutely. Yeah, great question. All right, we good with these numbers? This is like a long time for me. Like, I just feel like, why did it take them 80 minutes? But then like there must be a problem at this hospital back in 2016, you know? This is more kind of like what I see. Who did I have that stroke patient with that was a dissection? I feel like I had it with a resident maybe. So we had a stroke alert that came in, and she couldn't move her left leg, but she was talking, she says like, I'm uncomfortable, I don't feel good. My body hurts, and she had a massive dissection. And so like that dramatically changed who I consulted. Obviously I added the CTA, the CT non-con and the CTA of the head, because I don't think it extended into the carotids. There would have been a massive delay, right? And the reason naturally that she couldn't move her leg was because she had dissected all the way down into her femoral artery. Yeah, she had a malperfusion on the left kidney as well. So there's a lot of issues, and we diagnosed her really fast by I actually used the butterfly. So and she was in a stretcher, just because stroke patients don't have pain. You know, they're not hurty. There's like a weird, very rare thalamic stroke that can have some pain, but so this is, why ultrasound is beneficial. Now we know this is med school, right? We know, I think we just intim Voltaire, right? It goes in, it dissects through the media. This is what happens, creates this false lumen. We have these classification systems, right? I like the Stanford because it's easier, but the DeBakey is a little more descriptive. And there's this really sweet graphic here that this Radio Guyane person, I just Googled it and I found it, and I think it's a pretty good chart there. So it basically has to do with its location and where it's isolated or not isolated to. And then the reason why these classifications are important is because it helps determine appropriate surgical management. And it'll make you sound smart when you talk to the cardiovascular surgeons. Cool? All right. Oh, yes, go ahead.
From a disposition standpoint for these, even if it's just a medical aortic dissection, they should still be transferred to a facility with cardiothoracic surgery, right?
I mean, they can always extend, but that would be a conversation with the admitting docs at whatever institution you are at. Because some places like they're okay with that and some places they're not. So I would ask. But yeah, typically if it's just medical management, they don't need a cardiovascular surgeon, but they could move, especially in the acute phase. Extend, I guess. Any other questions?
Can I just comment on
Please.
One of the things to think about, Rouser, is that if you're in a Stanford B, especially way over on the right-hand side, especially if it's infrarenal, that's really not a cardiothoracic surgeon's territory. And in fact, most things that are in Stanford B are related to a vascular surgeon, not a cardiothoracic surgeon. All right. So definitely anything below the renals is only going to be vascular. If it goes above the diaphragm, there's some debate, but the cardiothoracic surgeons don't love being in that area. They like having the vascular guys. And a lot of times what they'll do is they'll just put in, it looks like a stent, but it's just a big aortic stent is what they'll put in let's say on the Stanford B side.
So there will be some surgical management for Stanford B.
What's that?
There will be some surgical management, actually.
Not always, no.
There's, I say potentially, right? Like it's medical management, but there's always like exceptions, I think. Yeah. Cool. Any other thoughts? No? All right. Sweet. Let's talk about the funner stuff, which is like how to diagnose dissection. So we have a direct sign, which is just identifying the dissection flap. But there's also indirect signs, right? We can look for aortic regurg, we can look for aortic aneurysms, and then we can look for pericardial effusions, which that is actually the leading cause of death in a dissection is tamponade. Now we're actually pretty good at diagnosing this at the bedside. Look at these specificities. We got 92% specific, 100% specific. This is a meta-analysis, 16 studies, 4,569 patients. And then the indirect signs, pretty specific, a little less sensitive. And that's actually how I use it. If I have a high suspicion or a suspicion and I don't see it, they're going to the CT scanner, right? But if I see it, I'm acting on it. And if they're stable, oftentimes sending them to the CT scanner is still appropriate because that is important for the surgeons to be able to plan out what they're going to do, right? So look for these secondary signs. We'll start with the primary signs, the flap. So we have normal on the right. Do you guys see the ascending dissection flap? It's a little subtle. You might have to watch it through a few cycles. There's a difference. There's a difference between the valves and there's something else over here and maybe even over here. But right there, you see that line right there? That is the flap. It is apart from the valve. That is what it can look like in the ascending portion. And I don't have the color image on this one, but I guarantee that there is a good amount of regurg. And you see that little like dot that's coming in right there? That is the descending flap right there. And you see it can be a little subtle if you don't watch it over a couple of cycles. And then we have normal on the other side just for reference. This is an arch dissection. Pretty satisfying view to obtain. It's like horrible for the person, but there's not too much else, right? There's no valves in the aorta. If you see anything mobile in the aorta, assume it's a dissection. Good with that? Yeah, this is a different patient that had a quite dilated descending aorta, and then you can see it's almost like two guitar strings over here. And this one did extend all the way to the root as well. This one's a little bit, I think, more easy to see. You see it on that left side, on that descending aorta, on that cross section? Right there. So you shouldn't see anything in the aorta. See anything in the aorta, it's abnormal. And then with that same patient, we can turn it into the long axis and you can actually see it kind of wiggling there. We good with that? Sweet. All right. We already talked about aneurysm, so let's talk briefly about aortic regurg and an effusion. Regurg is present about like half to 3/4 of the time, so it's frequently there, and that's actually one of the things I look at for potential for complications. So identify the flap. I actually look for regurg as how sick do I think the patient can get in a short period of time. And the cause of this is, part of it is they had an aneurysm to start with, which you don't need an aneurysm to have a dissection, right? But aneurysms are a risk factor for dissection. So you have dilation of the annulus because of the aneurysm. That can cause that regurg. You can have the dissection flap go directly into the valvular structure, and then you can have the flap itself extend into the valve. All of those are like the causes, and it looks like this. That's actually a pretty sick patient. You see the ejection fraction is already pretty low. They're already pretty like malperfused. See this as well. I'm a little more concerned. And then right here is the dissection flap. Just to show you. You can do an apical 2-chamber view. So instead of the probe marker to the left, when you're at the apical area, you have the probe marker up instead. And the more parallel you are to the flow of blood, the greater Doppler signal you get. The more perpendicular you are, the less Doppler signal you'll get. So if you can get a good view on an apical 5-chamber or an apical 2-chamber, that would actually give you the best kind of like regurg. And if you're not sure what color means what, there's this legend on every ultrasound. And if, blood should not be moving from the aorta back this way, we're seeing this red flame go back through the aortic valve. That's what regurg looks like. Cool? All right. Let's talk about effusions. This is less common, but 10 to 15% calf tamponade, which is like a large percentage. I actually had a patient, I've had a couple. Damn. I left a pee out. I left out the pee. What does tamonade taste like? Like, what do we make tamonade out of? Lemonade and hot sauce. Yeah, like tapatio. Is that what goes in? Is that the hot sauce? Right? It's tamonade. It's got to be tamonade. Is I actually kind of want to try that now. And then, wait, hold on. Wait, but then if you just put tequila, it's just a spicy marg.
Yeah.
All right. This is the cause. We have rupture into the pericardium. It can actually be an inflammatory response from the dissection, and then of course you can have the dissection flap go into the pericardium directly. These are pores holes here. So you see here how low the ejection fraction is already. This is a very stressed out heart with obvious pericardial effusion. This is not a big one. What do you think of this one? What is that thing? Yeah, it's a clot. It's a clot. It's a little wiggly boy. And you can see here that the right ventricle, which is how you diagnose tamponade, you're looking for diastolic collapse of the right ventricle. The right ventricle can't do anything. It's just being like such physically impeded by that blood. And that's what tamponade looks like. So you can look for that as well. I have had situations, too, in my entire career, where I've been able to temporize a pericardial effusion by leaving a catheter in. If you don't have the pericardiocentesis catheter, you just use a central line and just take out enough for their blood pressure to come up and then clamp it. And then if their blood pressure drops again, then you just take out a little bit more until you get them to the OR. It doesn't work all the time, but it's something that can temporize because if you take all of it out, then there's like negative pressure in a sense, and so more blood will dissect into it. So it's this weird, like, very delicate thing that is a very last-ditch effort that occasionally works. So for our one slide, this was, I don't know, every time I see these kind of studies, I'm like surprised, but also not surprised because there seems to be a very big consistency. This was a study that looked at type A dissection repair, and they found that there was increased prevalence in African Americans, and they had a younger age of presentation and a higher rate of high blood pressure comorbidity. Do you guys all know the how racist the GFR is? Do you guys all know about that? Does anybody not know how racist the GFR is? Okay, perfect. If you're shy and you don't want to just Google it, that's probably one of the reasons I think why African Americans seem to have a higher rate of problems is because they're diagnosed less than non-Black individuals. All right. That is the end of part 1. Remember, based solely on the traditional things that we have at the bedside, like our physical examination and x-ray, we might actually miss significant thoracic aortic pathology, but when you have the ultrasound at your fingertips, it really lowers that threshold for that diagnosis so you can catch these life-threatening pathologies before they become deadly. If you enjoyed this video, please check out our other videos on our YouTube page and on the Core Ultrasound website and podcast. I hope to hear from you soon, and happy scanning.